the, and I'm just going to actually be looking at this sort of like looking under the lamppost and in terms of looking at particular areas of the brain. Let's see, I'm trying to advance. There we go. So I'm actually going to talk about two different studies, both of which happen to have in common that they look at brain activity during the anticipation of reward in a task called the monetary incentive delay task. And I did the first study, and then because of that experience, I used it in the second study. And the first one is an fMRI study, and the second one is going to use intracranial EEG. So two different perspectives, sort of related to the same topic. So the first one is a study that was supported by the NIMH in a program related to the sort of more effective, more efficient development of novel treatments with the use of biomarker-based outcomes earlier in the development process. And that NIH effort was called the FAST effort, or for fast fail strategy. And I had the mood and anxiety disorders grant within that fast fail program. And one of the studies we did as part of that is to look at a new mechanism. At that time, was being completely ignored, and it was a kappa opiate antagonist that we studied. And we looked at the activation of the reward specifically during reward in this task, specifically in the nucleus accumbens. And we looked at it in people with depression and anxiety who had anhedonia. And I'll tell you more about that in a second. The second one is a completely different study. These are very, very severe treatment-resistant depression patients who got deep brain stimulation, had electrodes planted in their brain, and we looked at the intracranial EEG during anticipation of reward in the monetary incentive delay task. So I'll tell you what we found about these in terms of circuitry. But in both cases, the focus was somewhat limited. In the first one, it was on the nucleus accumbens. We didn't even analyze or look at data anywhere else until years later. And because of concerns about multiple comparisons and, with imaging, you can look anywhere in the brain. And then the second one, we had limited number of electrodes in the brain, so we could only sample from a limited number of areas. So the first one is sort of hopefully will help us think a little bit about the physiology of our reward system in a way. There's a huge literature in animals that supports that there is a system that modulates dopamine function, and it's mediated by a receptor called the kappa opioid receptor. Now, a confusing thing about the kappa opioid receptor is, while it's true that opioids bind to it, the most important ligand for the kappa opioid receptor functionally is dynorphin. And when dynorphin, and basically we all know about the dopamine neurons in the ventral tegmental area, and then they project to the nucleus accumbens. But it turns out that dynorphin, when it binds to these receptors, inhibits dopamine release at the level of the ventral tegmental area and the release of the ventral tegmental area neurons of dopamine into the nucleus accumbens. And we all know the dogma in the field is that the nucleus accumbens is the sort of central area of all reward. All reinforcing substances, everything that's abused, all reinforcing behaviors are all associated with an increase in dopamine in the nucleus accumbens. And so the fact that there is this dynorphin connection there has been studied in animals, and it's released by stress. So in animals, if you stress them, they release dynorphin, and then they get anhedonic. And the way they measure anhedonia, the anhedonia in animals, of course, is they don't say, what do you like to do? Are you enjoying what you used to enjoy? They have them. They look at whether they prefer sucrose or something like that, or a treat versus water, things of that nature. And and there's animal data that suggests if you block those kappa opioid receptors, then the anhedonia associated with the stress does not occur. And sort of based on this and some other animal data showing that the kappa opioid antagonists have antidepressant effects, which I didn't care about because we all know the animal models of depression aren't very good. Um, I got interested in this mechanism because Lilly had a drug that blocked the kappa opioid receptor, but it was at a time in history where companies in neuroscience were very conservative because they'd lost huge amounts of money on drugs that had positive phase 2 studies and then went into phase 3, a huge, $500 million phase, sometimes more than that, $700 million phase, and then they fail after that kind of investment. And Lilly had explored this for a substance use treatment, and it didn't fail. It didn't. It failed. It didn't advance, and so it was shelved. They said we're not going to pursue development. So I asked them, could we study your drug in our NIH supported program? And they said yes. So we started a project related to the use of these kappa opioid antagonists and probing this circuitry right here. This kind of our assumption is that our interest was focused on the nucleus accumbens. We studied the nucleus accumbens in an 8-week double-blind parallel group placebo-controlled trial where people all got this kappa opioid antagonist. Now that drug had been through basic science evaluation. Its toxicology had been mapped and was favorable. It had single ascending dose, multiple ascending dose studies that are the core of early phase development of drugs. It had really good potency and specificity for the kappa opioid receptor, and it was and 10 milligrams had been used and previously and been studied in a PET study that showed it robustly engaged the kappa opioid receptors. And for us, that was not a necessary requirement for studying it in this program, that we had a way to know how to dose it to make sure when we dosed it, we got a robust effect on the target, which in this case is blocking the kappa opioid receptor. Now, an unusual inclusion criteria for this study was employed, but it was employed because this was a program funded by Tom Insel. Tom Insel was director of the National Institute of Mental Health at the time. And of course, he had developed the RDoC concept along with Bruce Cuthbert. And they were very interested in cross-diagnostic phenomena like positive reward valence, things like aspects of anhedonia, what is covered by elements of anhedonia. And so we were basically forced, not in a bad way, but the idea was that we needed to study an RDoC dimension and do it cross-diagnostically and as a sort of model for how one might develop a RDoC-based treatment. So we recruited people who had a DSM criteria of either a mood or anxiety disorder, did not have to have depression, but they had to have an elevated score on the Snaith-Hamilton Pleasure Scale. Now, Maurice was saying earlier, there's no good anhedonia scale. We don't have agreement about what anhedonia is. I 100% agree. But we had to choose something to use at that point in history. And there was a little experience using the SHAPS in like 2 studies that had been done with an entry criteria of having a score greater than 20, and a treatment showed an effect with that model using the SHAPS. And so we used the same thing because that was the only thing there was precedent for. We could not find any other anhedonia scale that had ever been used in a clinical trial that had, detected the therapeutic effect of a drug versus placebo. So we used this with the understanding that there was a very loose ground upon which this entry criteria was based, but it was necessary because of the lack of precedent. And based on the circuit model, which I showed you before, our focus was on the nucleus accumbens, and we did fMRI, and we looked at the brain activity occurring in anticipation of getting reward in the monetary incentive LATOS, which I'll explain in just a minute. And we targeted enrolling 90 subjects. And so that was the primary outcome, and we only looked at that area of the brain because of the problems that have been observed with replication with many MRI-related studies, will assume to have some to do with spurious outcomes and chance findings. When you have a lot of outcomes, you can generate lots and lots and lots of variables from an imaging scan. So we had as clinical outcomes the Snaith-Hamilton Pleasure Scale and a probabilistic reward task developed by Diego Pizzigalli, who was part of my team. And this is the monetary incentive delay task. Basically, you get shown a series of pictures, and in a sequence where you get one that tells you a symbol, and that symbol, as you can see on this figure in the bottom, is coded with a monetary amount. You get told right then for this upcoming trial, um, do you um, you have the capacity to win money, have no win or loss, or lose money. And the physiology is obtained during the period when you're told whether you can win or lose, and when the game starts. Like for each, there's trials, a series of trials. So for each trial, you get this anticipation cue. In this case, the circle with the horizontal line in the middle, and then you get a plus, and that plus tells you now you should. It's basically a simple reaction time task after that, and they set a range of reaction time you have to hit, and you win if you get in that reaction time, and you lose if you get outside that reaction time. But you only get but what happens with outcome is dependent on what the anticipation cue was. So if you made it in the time interval and it was a chance to win, you win money. If you made it in the time interval, the right time interval, and and it was a lost trial, then you would lose money. And if it was a neutral trial, it wouldn't matter. So hopefully that will help people understand sort of the basics of the task. If anyone has any questions, please um, let me know. This is a task developed at Stanford by Brian Knutson, who I'm sure, Alan, you know well and probably worked with.
Yeah, we share a K awardee together.
Yeah. So, and been used in a fair number of studies, but we were at a point in history where uh, there was not enough data to use this as an entry criteria, like the activation in the nucleus accumbens during this task. We wanted to, but there just was not enough basis for it, and we had to use that SHAPS criteria because it would have been arbitrary to set some threshold and with this task. It's just never been done. There was no public literature. So we had other measures of anhedonia in there, or related phenomena. People are probably aware in the RDoC, there are three different dimensions of reward function that are defined. Basically, reward anticipation and experience, motivation, and I think, what is it called? Things like enjoying eating things and that nature. Uh, Consumatory reward. I think those are the three, if I recall correctly. So and none of the anhedonia scales are very well aligned with that. The effort expenditure, the temporal experience of pleasure scale has a consumatory and anticipatory component, which are two of those three RDoC dimensions. So a way that may be lined up a little bit. And we did the Hamilton Depression and Anxiety scales, even though people were not required to have one of those things. You could have either one. So this was not a very depressed sample. And a lot of people who I've talked with about this particular study raised concerns about the fact that as I show you, we didn't show an antidepressant effect, but we had only, I think it was a little over half of the people had depression, and it wasn't particularly severe. We didn't have any depression entry criteria. You just had to meet diagnostic criteria. But just to jump to the chase, because time is limited, we showed a very significant effect in the ventral striatum as the primary outcome measure, that the drug increased the activation in this region of the brain more than placebo. And the clinical outcome measure, SHAPS, also showed improvement versus placebo. And some of the other anhedonia measures did not show effects, but this just shows you the effects of the clinical measure, the Snaith-Hamilton Pleasure Scale. And these are the other measures that this response bias in the Diego Pizzigalli's probabilistic reward task were positive. All of the imaging measures we looked at were positive, every single one. So this is and this is all nucleus accumbens. This is ventral striatum, another term for nucleus accumbens. We looked at the maximum, what we had as primary outcome was the mean activation in the ventral striatum in anticipation of reward. And this is the maximum here, and the mean striatal activation in anticipation of loss, and the maximum anticipation of loss activation. And lo and behold, the biggest effect was not the one we specified as primary, but the anticipation of loss effect, the mean effect in anticipation of loss. So many people had assumed, and I did, that the nucleus accumbens was activated by reward only. It turns out it's equally activated by loss anticipation. And I looked this up after the fact, and I found there's a whole literature around this. This is not actually surprising, but it was not known to me. So we didn't consider making it a key outcome measure. But it just helps flesh out the idea of what that key reward circuitry is supposed to do. It's not unidirectional. It has a whole dimension from loss to getting rewards, all coded in some ways. So just exploratory post-hoc analysis that is relevant to what we're talking about here a little bit. So first of all, the primary outcome measure and the secondary outcome measure were correlated. The change in imaging activation was correlated with the change in the shaft, which is reassuring. It just says they're measuring some similar things, hopefully. The correlation was only 0.2, so it's not something to get super excited about, of course. This is a modest size effect. But two other observations. The baseline ventral striatal activation before treatment was a strong predictor of with the change in ventral striatal activation. So the more anhedonic the person was, the more improvement they experienced with the task. I mean, with the treatment, excuse me. And then we combined this was for work with Alan and Leanne Williams to look and see if we could identify sort of a patient type based on the SHAPS and the ventral striatal activation. And we were actually able, with a combination of the SHAPS and the ventral striatal activation and MRI, we could predict with 90% accuracy who would get better with treatment. So just what is the conclusions from that study? It looks like there's a role of nucleus accumbens dysfunction in anhedonia. And from the point of view that there was a correlation between increased activity in anticipation of rewards in the nucleus accumbens in this treatment, it could have been any treatment, and a scale that was designed to measure anhedonia, as Maurice points out. I'm not 100% sure that I should call it that because it's just one way to define it, and it may not be a particularly good one. And but it also speaks to the monetary incentive delay task as being linked to anhedonia circuitry because it brought out the effect of this drug, which was related to improvement in pleasure according to the scale, and in basic science literature over and over again shows an effect that increases the pleasure and the anticipation of pleasure and the interest in things in animals. I think this establishes the nucleus accumbens as a place where dysfunction happens. But again, this is looking just at one place in the brain. We later, like this is many years later, looked at the whole brain results, and it turns out there's a kind of complex network of subcortical activities that change in anticipation of reward or don't change, that were correlated with anhedonia, but nothing as single area as strongly as the nucleus accumbens. That seems to be a critical point for driving this dysfunction. Failure to activate that area when there's a potential to get a reward or a punishment. And the other thing is this, I just mentioned a minute ago, using the SHAPS and the fMRI activation, if you can predict who's going to get better with this treatment, it defines a patient type. It doesn't define a disorder necessarily, but there's a group of people who respond to kappa opiate antagonists and get better to some degree, and they are detectable by biomarker. And I'm not sure if I should call them anhedonic. I'm not sure what to call them, because I think the fact that we don't really have agreement in the field about what this SHAPS is measuring makes it a little challenging. But it's a scale intended to measure anhedonia and asks questions about pleasure of different sorts. So it's kind of in that domain. But it may be a specific kind of anhedonia that responds to this treatment. So now I'm going to switch gears completely and look at a different study using the monetary incentive delay task, but that actually was started. The analysis was started by a neurosurgery resident who's working with me on this deep brain stimulation project, who specifically had interest in the role of medial orbitofrontal cortex. And I said, okay, fine, you can look there, but we have to look at everywhere we have data, and we'll see what we find. And so this is just the idea that there's data that suggests that the medial orbitofrontal cortex has some activation pattern that is associated with the economic value of things. So if something has a high economic value, then it starts firing. If it has a low economic value, it doesn't get activated, or no economic value. And economic value is reward, essentially. It's like the way some researchers in some fields refer to what we think of as something of value to a person, something that would be desired by that person. And this just shows you what we're talking about here, and the regions that we're looking at in the orbital frontal cortex. And this is the medial portion, which is, you're looking at sort of the brain cut in half there in the front, and it's the side that, like, it's areas 14, 12, 14, and 13 there that are medial, and also 47 and 11. So it's a group of areas, and I'm going to tell you about and this is just the data that sort of has been published that supports that story, that shows that in anticipation, or when things have higher economic value, you get greater activation in this in prior published literature. So that's what drove her to be motivated. I was motivated because I had just done a study with the monetary incentive delay task with imaging, and now I wanted to see what it looked like with a different kind of measure, in this case, intracranial EEG. Do we replicate the same kinds of findings? So in terms of this story, there's obviously evidence that depressed patients have decreased sensitivity to reward in a number of ways. And this, in depressed patients, people showed a decreased sensitivity to reward in terms of the magnitude of activation in the bold fMRI signal in a task previously by Z and colleagues. And but nobody ever has looked at intracranial EEG data. So we did a study that obtained intracranial EEG data, and we recorded the monetary incentive delay task, and allowed us to look at this from a different perspective, from the physiologic perspective based on electrical activity, as opposed to the bold signal, which is a blood flow measure and is a proxy for activity of neural structures. And in this study, we targeted 10 areas, which is 5 areas bilaterally. The ventral striatum, which includes the nucleus accumbens, and ventral capsule, which is right nearby. So this is sometimes known as the anterior limb of the internal capsule, which is, it's not the nucleus accumbens directly, it's like right next to it, but brain electrical activity, volume conduction is likely to pick up some activity from there. The subgenual cingulate, the amygdala, the orbital frontal cortex broadly, and the hippocampus. So we get a number of contacts in those places. But these are the sites of the distal contact of 10 different electrodes, where there were 15 other contacts in the brain that happened to be along the path. And in one of the subjects, we had a contact directly in the nucleus accumbens, and in the other one we didn't. I only have data on 2 people to show you so far, but so this is very, very preliminary. Not to get carried away on on data from 2 subjects will be important. So I'll just give you a little background for this study. For me, it's a very interesting exciting opportunity to be part of this unique study, which is only possible because of a collaboration I have with a neurosurgical colleague, Eddie Chang. And it's a big team doing this. I'm, you know, just one of the members of this team. And and we started this study with a different hypothesis than has been used in deep brain stimulation studies in the past. There have been a number of studies of treating people who have failed everything and have depression with deep brain stimulation. And you know, those studies turn stimulation on and leave it on day and night for years. And from my point of view, they don't know where to stimulate. And depression is so heterogeneous, as we were talking about earlier, uh, and the diagnoses are so fuzzy. You know, we were having a belief earlier in this discussion that the diagnostic criteria actually don't line up with data. Where is pain? Where is irritability? Where is anxiety? So it's not clear what depression is, but I feel like there's unlikely to be a circuitry of depression specifically, that there probably is different underlying dysfunctions in different people because it's so heterogeneous. And that's to me consistent with what's been found in the past, that different neuroimaging studies have failed to replicate or found different things. And we have a whole accumulated set of areas of interest in the brain. And that's why we implanted 10 to start with. And they were the 10 we thought of were most promising. But we took a different approach to this. One of them is the personalization issue. But the personalization is possible because of a fundamental shift that we introduced, in that we believe that it is possible to achieve immediate therapeutic effects from direct stimulation with people with depression. All of the prior DBS studies, the deep brain stimulation studies, have had taken people from 3 months to 2 years to show therapeutic effects. And it's typical, like with antidepressant medications, to take 8 weeks. And Alan was talking earlier about the idea that we have ketamine that works rapidly, and there's a lot of interest in rapidly occurring treatments. We know it is possible. Like I've given, I'd say, like 40, 50 people ketamine or esketamine now, and it is amazing to see some of those people have immediate remission in front of you after a 40-minute infusion. Like they're immediately better. So we went into this with the hypothesis that was possible. And then the other one was, we thought it's possible to stimulate only when needed, using a closed loop approach, where you record a biomarker in order to help yourself do that, an intracranial EEG measure that's correlated with depression symptoms, and have an automated process where the severity of depression is detected with an intracranial EEG marker that triggers stimulation when you're starting to get more depressed, and you stimulate only then. And because for me, one of the uncertain things is it good to be stimulating when people are asleep? What's it doing when people are asleep? What is it doing when people are not depressed and you deliver brain electrical stimulation? What are you doing? We have no knowledge of this. So to me, it's better to be conservative and stimulate only when needed, and to try to see if you could get by with the least amount of intervention. So these hypotheses were based on the fact that we had a grant from DARPA. Eddie Chang was the principal investigator, my colleague in neurosurgery, where we found in OFC a place where you could stimulate and get an immediate antidepressant effect, and that there was a biomarker of mood that seemed to decrease when you did lateral OFC stimulation. Those are the ingredients you need to do this closed loop approach. A biomarker that's responsive to stimulation in a place that leads to improvement in symptoms. Because otherwise, you can't have a biomarker trigger treatment if that biomarker never says it's time to stop treatment, because because when the patient's better, it would obviously just be the same as stimulating all the time. So we then put in we use that strategy, and once you accept that you can have an immediate effect, now you can do surveys in people. You can optimize dosing. You can try different areas, because you can't try 5 different areas when it takes 6 months to see if there's a therapeutic effect with one location. But you can if you can see benefit in a minute or 5 minutes. So we explicitly adopted that strategy by having basically a trial and error personalization period for both location and stimulus parameters. and to try and find the best place to stimulate each person, to have a highly personalized approach, and then to use a device that is on the market for treating epilepsy to do this closed loop thing. There's a closed loop strategy existing for treatment of epilepsy where you record a brain electrical activity pattern. When that when it's present, trigger stimulation only then, with the idea that it's picking up seizures and that it's going to stop seizures by doing it. Interestingly, I thought that it worked when I started this. I thought that worked well, that you picked up the seizure activity and then you stop the seizure activity. It doesn't. It's not actually very functional, and it doesn't work in this mode. It detects a pattern of electrical activity and then stimulates, and then you don't see changes for weeks. So it's it's a little counterintuitive, but fortunately our model was different. So now I'll tell you sort of a little bit about this study, and then we'll move on to the relevant findings related to this conference. So after we implanted people, we had them in the epilepsy monitoring unit for 10 days, where we did this stimulus response mapping, trial and error, to see if people's depression improved. We asked them to rate their depression over and over and over, which I thought would be garbage. Like asking people to do that 20 times a day, like how useful could that be with very crude measures? I'll tell you in a minute. So it's surprising I could find anything at all. But we have them there for 10 days, and we do this mapping, and we try to find the best one or two places to stimulate, and then we remove the electrodes, and then if there is a place that improves them significantly, then they get to go for the long-term treatment, which if there's a biomarker we can find, then it's used to trigger closed loop stimulation. If not, then we would just do standard open loop stimulation, because we want to give those people they'd have the option to do it, to give them a chance to get the therapy, but we wouldn't be able to do that closed loop. So then they get this epilepsy-approved RNS. It's called the NeuroPace RNS device implanted. And then we'd have a year to optimize the closed-loop strategy. Then we'd do a blinded crossover. So this just shows you the 5 locations bilaterally that we implant: subgenual cingulate, ventral capsule area, the ventral striatal area, orbital frontal cortex, hippocampus, and amygdala. And the way we assess depression severity for the outcome is the Montgomery-Åsner Depression Rating Scale. And we did it throughout the trial every week, and we had the Hamilton Depression Rating Scale as secondary. But when you have a treatment that can change immediately, you can't use those scales. Those scales cannot possibly detect a treatment that works in 40 minutes like ketamine, or deep brain stimulation, which may work within 10 seconds or 30 seconds. You can't, because it asks questions like, how'd you sleep last night? And that people don't get a chance to sleep in the period from when you start treatment to when you're assessing outcome. It's the middle of the day. So we went with the Hamilton 6 depression scale, and there's a self-rated version of it that's validated against the clinician-rated version. And then we asked people to do visual analog scales of about 4 different things, one of which was depression. So our primary way to assess the benefit of things was the Hamilton 6 depression self-rated scale versus the visual analog scale of depression. And I included in this something different than every other deep brain stimulation study. Every other deep brain stimulation study said, okay, we're going to treat people who failed everything. They have to fail ECT, they have to fail everything. And my view is that is going to select for somebody who might not be able to respond to anything. They don't respond, have never, ever, ever responded to anything. So we required that they were failed everything, but they had to have had at least a transient response to ECT or something. And if they had some transient response, then we would take them, with the idea that, particularly if they had a transient response to ECT but couldn't stay better unless you did ECT so frequently that it was cognitive impairment that was prohibitive, then they're kind of a setup for a model where you have a treatment that can be delivered long term without having to come into a clinic and to get it, and that doesn't have cognitive impairment associated with it, assuming that were the case. So I just want to show you summarizing. We've had 4 patients go through this 30-day epilepsy monitoring unit period, and lower is better. So if you go down, that means you had improvement in your visual analog scale of depression, which is what I'm showing here. And it's just going to require a little bit of explanation, so don't try to understand it yet because it'll be very confusing. Each of the vertical sort of columns here, where it's a sham, LVC, RVC, LOFC, are this is going from left to right. First, the results of sham stimulation, because everything we did was sham controlled, and then going to the right, the best stimulation response site for each of these individuals in terms of the need. And so if you look at this, it turns out that the ventral capsule was the best place to stimulate the first patient, but there isn't much change. And the reason for this is we didn't start to assess outcome until after we had done initial safety mapping and sort of preliminary. So we would go and we'd stimulate in the area, we'd do it briefly, and we'd increase the amplitude. And if we saw after discharge, which is a prodrome herald of potential epileptiform activity, we would stop and we would never go back there. And so we did this, and in our first patient, during the phase of safety mapping, she had a profound response to stimulation in the ventral capsule immediately. And it was so profound that it changed her world perspective. She said, I can't believe this. Like, I'm my old self. And she was that way only for like 30 minutes or 10 minutes, whatever it was. I can't remember at first. And so that she was so much better. There wasn't much room to improve. She had hope. She had like, it really changed things. She's the only person that happened with, that it was so profound that they were so much better that we couldn't really assess other things as well. So the two ventral capsule sites were by far the best, but it only shows a small change. So that's the left upper right corner, that there's a small difference, but the ventral capsule sites were clearly the best, and profoundly so. Then the upper right corner is the second patient. Pardon that it says 03, because it's just the second person was consented but didn't continue. This person had biggest effects in the orbitofrontal cortex and the subgenual cingulate, and was very clear. And we had two good sites in that person. And so we actually implanted both of those sites because there was also biomarker potential in the orbitofrontal cortex. So we could have two shots on goal for the second phase. And by the way, in the first person, we implanted the right ventral capsule and the right amygdala, which was her best biomarker site. And then in the lower left corner, you see that person's best site was, it says left subgenual cingulate, but that contact on the left subgenual cingulate lead was in nucleus accumbens. And her best response was from nucleus accumbens stimulation. And then she did well with ventral capsule, which is next, but she had so much anxiety that it wasn't tolerable. She could differentiate the anxiety and the depression improvement. And it triggered anxiety. It made it worse. And so, and the orbitofrontal cortex helped, but it made her sleepy, and she didn't like that. And so the fourth one, the subgenual cingulate, became the one we took forward along with the nucleus accumbens. So she had nucleus accumbens and subgenual cingulate. Again, we could implant two because we had a biomarker that worked for that person. And then the fourth one in the right lower corner, like the first person, had a profound response to ventral capsule stimulation. This anterior limb of the internal capsule, and the bed nucleus of the striae terminalis, which is some of these leads that say ventral capsule. I don't say which contact it is. Somewhere in ventral capsule and somewhere in bed nucleus of striae terminalis. Bed nucleus of striae terminalis is a nearby gray matter area. The ventral capsule is a white matter area, right next to the nucleus accumbens. So she showed a profound response, but that wore off pretty quickly. Typically, what would happen is people would get that had benefit from a site would get an immediate therapeutic effect, and depending on the area, it would last anywhere from 10, 15 minutes to an hour. And then we started doing repeated stimulation because we had to implement a repeat stimulation paradigm. And if you repeated it, for like, let's say 10 minutes, doing like 5 seconds on, 30 seconds off, you could get a person better for a couple hours. But and so the one conclusion here is that it was possible to find a site where you could stimulate and got immediate improvement within a few minutes, sometimes faster than that. In each of the first four people, it was reproducible. We did it over and over, and we compared it against sham always. But it was state dependent, which is really interesting. Because I do sleep, I was attuned to the fact that sleep might be important in affecting circuit state. And if you stimulate a brain region while a person's drowsy, the membrane potentials are at a different point than if the person's activated and highly alert, right? So that should affect the results of stimulating there. And that is, in fact, what we found in the orbital frontal cortex and the subgenual cingulate, but not the ventral capsule area. That area, it didn't matter what state you were in, it always was activating and was always antidepressant for the people who had a beneficial effect in that area. But the best site was different in all four of the first people, which speaks to the personalization need for treatments for depression. I mean, it was very obvious. There are some sites that have been good across people. Like the ventral capsule site activates everybody, but causes prohibitive anxiety in the second and third person. So it always tends to be like it's like taking a stimulant in some ways. It always is stimulating, but whether that's a helpful experience for a person depends on their personal set of symptoms. And the subgenual cingulate was helpful for everybody except the fourth person, where it was absolutely no benefit. And the orbital frontal cortex was helpful a little bit in the first and well, to some degree, not as much as other places, in the first and second person, but not in the third or fourth. So heterogeneity. So we do the monitoring incentive delay task while people are in the epilepsy monitoring unit because we have the opportunity to study the same person when they are depressed and then when they're not depressed 5 minutes later. So it's the best control for state and individual in doing it within individual study where we could know that the person was going to be better. And because we would like say, oh, okay, so the ventral capsule site worked very well in this person. Now let's do a baseline monitoring center delay task once they go back to doing worse again, and then we'll repeat it once they get better. And so that's what we did, and that's the data that I'm going to show you relevant to this story. Both the second and third patient were excellent at performing the task, and they in the way that it was intended. And so we're analyzing them. The first and fourth person have not yet been analyzed by the neurosurgery resident who's doing this analysis. So I apologize, I only have data from two, so we'll have to stay tuned. And we have our fifth patient in 3 weeks, so we'll get another set of data, which I could potentially share. So we looked at them when they were depressed and not depressed. So here's actually the third patient. I don't know why I presented it in this order. They were in a state where they had very little depression here. They had a 2 out of 18 on the Hamilton 6 and a 26 out of 100 on visual analog scale of depression. And you can see that when they get stimulated, when they're in anticipation of reward, they get this big increase in the orbital frontal cortex in the high gamma. And then if you, in anticipation of loss, there's nothing. So this is orbital frontal looking like it's showing a signaling capacity for detecting reward. This is the same person when their depression severity was 4 out of 18. Excuse me. This is the other patient. So these are the first two patients, also not very depressed. Depression rating scale score of 4 out of 18 and the visual analog scale of 28 of 100, very good. And also had this activation at 0 is when they get told they're going to get a reward, they're going to get a punishment, and they get this bump in activity in orbital frontal cortex and the medial orbital frontal cortex in both people. So then what happens when we study them in the depressed state? So here's our second patient called PRO3, where you see on the left what they did when they were not depressed. On the right, the visual analog scale of depression was 78 out of 100, and their Hamilton depression rating scale score was 14 out of 18. And there is not an elevation in anticipation of reward here like there was when they weren't depressed. Like it failed to activate during that phase, but they did activate in anticipation of loss, which didn't happen when they were not depressed, interestingly. And then the other patient, this just goes to show the same phenomena, but not the loss issue. So here's on the left is the person's activation in the orbital frontal cortex when they were not depressed, but on the right they failed to have that activation in the orbital frontal cortex when they're depressed. and they don't, in this case, they didn't activate to the loss really at all either. So um, and this the neurosurgery resident looked to see this was, although she had a particular hypothesis and interest in that site, she went into this agnostic and looked around the brain at all the sites that we could record from that were in brain, which was about 80. And there was really only findings in this medial orbital frontal cortex area that were linked to differences in the high depression and low depression state in these people. There was a patchy little some mild changes that were present here or there, but nothing that was consistent anywhere else, which surprised me. But in one of the patients, we didn't have a contact in nucleus accumbens. We had the ventral capsule site that was right next to it and could be argued could have picked up something there. But so it's a little bit looking under the lamppost. But that, if you take all of the sites that were positive in orbital frontal cortex, they all show this response right after the cue that tells them they're going to get a reward very reliably, all of those sites. And in the high depression state, there was nothing. So I'm not so much interested. She was very interested in the issues for decision making, which is relevant here because ability to process rewards and it's really anticipate rewards is important for decision making. But I'm just sort of looking at this in a broader way in terms of the Anhedonia story. I'm just going to jump here. So we've talked about two different studies where we've looked at neural circuit activity during reward anticipation and the monitoring and the delay task with different methods with access to different spatial distribution. And it looks like there's two different kinds of parts of the brain involved in some way at least. And in people who are not depressed or mildly depressed but have anhedonia and then they get better, when they get better with a kappa opiate antagonist, and that's key, it's with a kappa opiate antagonist, it shows sort of improvement in activation in the nucleus accumbens from when they're less anhedonic to when they're more anhedonic, with a caveat that anhedonia was measured with the Schaff scale. And then with these very severely depressed people, when they're depressed, they don't activate in the medial prefrontal cortex in anticipation rewards, but they do when they're better. And it's possible that why would we care about the circuitry? Well, one, we want to have means to measure this phenomenon and have a biomarker for it. Like, I mean, I was envious when Alan was talking about this psychotic depression story and having these glucocorticoid, mineralocorticoid kinds of measures that you could look at. That's important. We need to have those things because our diagnoses are so messy. And so, and then the other part is ability to target treatment, a means of focusing animal and human research on particular areas of the brain that can be targeted by brain stimulation measures or pharmacologic measures. So I'm going to stop there.